Time now for this week's Health Matters. Paul Critz with you, and I've got PA Lynn Szabo, our host, on the phone today because she is not in the studio with me. How you doing today, Lynn?
I'm doing great. I'm calling in from the Bay Area where I'm visiting my parents. So, yeah. So thanks for making this happen.
Oh, no. And it's good to visit your parents. There's a little point. If you've got parents out there to visit them.
Go do it.
So I saw the topic for this week, and I'm super excited about this. This is something I'm curious about.
Yeah.
I don't know a bunch about. Big historical thing. Tuskegee. All right. What do we need to know? What's going on? How do we get into this?
So formerly titled the Tuskegee Study of Untreated Syphilis in the Negro Male, which was initially started by the U.S. Public Health Department and the CDC in 1932. But weirdly, it lasted until 1972,
Ooh.
although it was only supposed to be six months initially. I was interested in this because it's Black History Month, but also because it's kind of medically, ethically it's horrible, and we'll get into that, but medically, I don't even know why they felt like they needed to do this.
Oh, wow. So what was the goal?
The goal was, there was a study from Norwegian men, and it was retrospective. That means they looked at a certain point in time and looked backwards. Okay, and they were trying to, at that time, they were thinking that in whites, syphilis affected the nervous system, and then the hypothesis was in Black men that syphilis would affect the cardiovascular system more than the neurologic system. And so they I don't even know how you can compare it. It's kind of apples and oranges in so many ways. But so they had 600 African American males, which 399 had known latent syphilis, and 201 were unaffected control group. And they went to great lengths to make sure that the people who had syphilis were kept uninformed of their illness. Mm-hmm. So what they told them was they had bad blood. And for this vague diagnosis, they gave them placebo treatments, known ineffective treatments, and presented things like lumbar punctures, which is the way you study syphilis' effect on the neurologic system, as actually treatments for this bad blood diagnosis.
Oh, my God. Okay.
I know, isn't it awful? Mm-hmm. So study lasted over 40 years. None of the infected men were treated with penicillin, even after it became a widely used treatment in the mid-40s. And another thing I should add here, when some of these men actually were enrolled in the Army, during World War II and probably the Korean War, maybe even Vietnam War, because it went on for a while. And they were tested for syphilis as part of the enrollment into the Army, and that positive test was suppressed.
Wow. So yeah, hiding your own conditions. And now, did they give syphilis to anybody?
No, and that's actually kind of what the communities of color believe. But
right.
No, they didn't. I guess you could say indirectly they did, because these men had wives and children.
Sure, and they just didn't tell them they had syphilis.
Right.
That's tantamount to the same thing. But yeah, that wasn't
right.
Okay. Direct
right.
infection. Wow. Okay.
But not the individual men that were enrolled in the study. They were known to have syphilis in the beginning of the study, and nobody was infected with it. Wow. That was another study actually in Guatemala. There's a parallel study to this that's even more insidious, with indigenous people in Guatemala, carried out also by the U.S. Public Health Service.
Oh my God! So
keep in mind that these men also had wives and children who were also infected. So we just said that. So I wanted to kind of put a nod out there to the initial dissenters, mm-hmm. because there were actually a lot of doctors and investigators who were aware of the study. And they started speaking out against it in the 1950s. So Austin Delbert, Albert Eiskrat, Count Gibson, and Irwin Schatz, looks like they were the initial people who were speaking out against it. Mm-hmm. But they were largely ignored. In fact, any kind of letters that they wrote were kind of filed in the circular file, and nobody paid attention to it until the 1960s.
These dissenters, were they physicians? Were they part of the study? Yeah. I missed the setup.
They were not part of the study, but they were following the study, and they were willing to call out the ethical concerns that they had.
Right.
But they were completely ignored. So, but in the 1960s, a guy named Peter Buxton and another man named William Carter Jenkins published articles in the press that were critical of the study, and they called for its end. So what really got this study to end was not any kind of ethics committee or any kind of personal, discomfort with the original investigators. It was actually the press. Mm-hmm. So in 1972, Gene Heller reported in the Washington Star all about this study, and the next day, Congress immediately responded with hearings that resulted in ordering the end of the study.
Wow. So it just took like breaking it wide in the public is what it took, but actual concerns from physicians and people in the medical field, no, that wasn't good enough. But if everybody's going to find out about it, we better do something about it. My God.
Right. And I think something like 30 people died, which was a smaller number than I would have thought, but I wasn't able to really find statistics about, who suffered psychosis, because that's a problem in late syphilis, or whose baby was born with cognitive deficits because they had congenital syphilis.
Right. My goodness.
So, and that's really only looking at the original 399 men, and not all the other people that were infected and affected.
So, but this study, of course, just culturally, especially in the communities of color, just casts such a long shadow and undermines so much. Even when I was doing the class inside Pelican Bay, and there were some African American inmates in there, people I'd worked with, students in classes, and there were a couple of them who were, this is during the pandemic, during the COVID pandemic, who were not. Right. Who are adamant, I'm not getting the vaccination, and I'd ask why, right. And they'd say one word, Tuskegee.
Yeah, I've heard that in the exam room myself, Tuskegee, and there's really nothing else I have to say.
Right.
I don't understand. Syphilis there was no known treatment for so long. I think the natural history of syphilis, if you wanted to divide it up into races, was largely already known. So besides the ethical horrendoma that this is, this knowledge wasn't needed. Mm-hmm. This knowledge was already had by accident,
Well, yeah, but the very premise of what they were examining right. was a different effect on African American males. It just, it's almost like they were trying to check their own racist assumptions about the physiological differences between the races.
Actually, and they also had this kind of vague theory that men of color didn't really care if they had syphilis.
Oh, wow.
Yeah. Oh, it was awful. But anyway, repercussions, you touched on that. So super medical mistrust of the African American community as a result. Mm-hmm. But this resulted in a drop of life expectancy for African American men compared to white men by about 35%. Of the difference between these two groups can actually be, kind of seen as a result of Tuskegee.
Wow.
That's a lot. And considering life expectancy for African American men when they measured this was only 45 years.
Oh, geez.
That's a lot of life to give up.
Yeah. And across the board for an entire population born from the mistrust of this that was bred in this population. Oh, my God.
Right. Absolutely. And then, another thing, I might have mentioned this already, but that it was one of the original investigator said it was actually, when he was questioned about the ethics of the study, diverted and said it was helpful that the men were illiterate and they couldn't read. So it hit the news. They were largely unaware of it for a long time, which is bizarre. So it is also widely believed participants were intentionally given syphilis, and they weren't. The original participants were not given syphilis, but indirectly their wives and children also got syphilis.
Wow.
So, yeah. And, my research brought up that there were an unethical medical experimentation happened way before Tuskegee and community the color. And like a lot of cadavers in medical school, like from the Civil War, were soldiers of color who were actually, kind of, instead of being buried like their family had hoped or returned home like their family would hope, were actually diverted to medical schools where they were used in anatomy labs.
Oh, man, because they didn't matter as much. Wow.
They didn't. There was also in the 40s a parallel study that happened. This didn't really affect, and I mentioned it briefly earlier, but it didn't really affect men of color, but indigenous peoples in Guatemala. A similar study only went on for 2 years, but they intentionally gave prostitutes gonorrhea and chlamydia and syphilis, and then sent them out to the clientele, which I think were soldiers. And they intentionally gave people enough of a dose so that, and in multiple diseases, so they actually died.
Wow.
And not of syphilis, but one woman actually died of gonorrhea.
Oh, my God.
Yeah. So, and that involved women, and I can't imagine what medical benefit that was at all. So, like you mentioned, the African American community more likely to believe that the federal government was also the cause of the AIDS virus. And I did hear that when I worked in the Castro from a number of people of color, that it was kind of widely known that they thought it was an attempt by the federal government to actually kill out quote unquote undesirables. So that's why it went into that IV drug abusing the gay community and communities of color. And that's particularly insidious because, the African American community is plagued by sickle cell. And the sickle cell, I did a rotation working with sickle cell kids in North Carolina when I was in school. And almost all of them had, through a history of blood transfusions, actually had AIDS.
Wow.
And I was there kind of when they were telling like the 17-year-old boys how this AIDS diagnosis might affect their sex life. And they were like obsessed with that. And they weren't really telling them, this is immune collapse. We don't have any medicine to treat this.
Right.
These are the illnesses you can expect to have. So it was interesting, the doctors that I worked with were more obsessed about their sex life and the spread of the virus than they were actually trying to keep these young men healthy. I thought that was bizarre at the time too.
Why do you think that was?
I think actually there's a subtle ingrained racism that makes maybe older white men and maybe definitely white women think that African American men are over-sexualized, and that's a threat on a bunch of levels. Not only maybe in some circumstances to the person, individually, but also in this case as a vector of disease that would be hard to control.
Right.
And these kids were just like shocked. They didn't really know what was being said to them. They didn't get it. There were no parents around.
Wow. Wow.
Yeah. So subtle.
Yeah. Well, yeah. And so subtle, and you can't even see it really. You almost need somebody from the outside to go, "Hey, what are you doing?" As a healthcare provider, as a somebody who in the trenches with all of this that's going on, how do you combat something like this in the exam room, confronted with a cultural difference based on some? I mean, yeah, there's some misinformation and some disinformation, but also some, a history of very real bad stuff back there that people should be aware of. How do you combat all of that in the exam room faced with a patient of color?
So what's my role in that? Am I the provider or am I the student?
You're in an exam room, and you've got yeah, yeah.
Yeah, I think I listen to them. I think they have to speak their truth. I think I'm not trying to like enforce my viewpoint. I'm listening what they have to say, and then I might bring up a point or two, like, have you considered? Like, it's really easy with, this is a slightly different situation, but a 17-year-old boy doesn't have any symptoms of an STD, but has a bunch of partners who are infected with chlamydia, and he likely needs to be treated. So you just kind of drop the information that, the most common symptom of gonorrhea and chlamydia is no symptom. And they're shocked for a minute.
Right.
And sometimes it gives them a different way to think about it. And sometimes it doesn't. And sometimes you're planting a seed that you hear later. And then, of course, after you've listened to them and maybe made a point or two, that, and then you say, look, my door is always open. You think about this, if you have questions, come back. So coming back doesn't mean that you're going to be forced into a treatment if you feel like it's not right for you. This is an option. And I'll oftentimes say in a room, we have a decision-making point. But I say that to everybody, that's not really specific to race. And I say, does this make more sense to you than this? And then, we can proceed whether it's, more direct to what I think is a desirable outcome, or whether it's more indirect and more of a learning process till we get to where, they need to be.
Right.
It's not necessarily where I need them to be. So.
Yeah. But it takes a while to get there, and you kind of have to, like you said, plant the seeds and steer the craft and try to get them moving in the right direction to.
Yeah, if you listen, that's like 90% of the battle.
Is it a matter of and then you listen, and then what? I mean, is it a matter of being able to present facts? Are facts even trusted in a situation like that? I mean, it almost seems like you're beyond being able to defend or to refute anything once you're into a base belief like this.
Right. I have no credibility in the face of Tuskegee. Absolutely. Yeah. I totally get that. But I might say, now we look at it, here's this crucial piece of information. Here's another one. I try not to argue my point, but have you considered?
Right.
And just like a base point or two, and then say, look, when you're ready to ask questions, come on back. If I can help you anymore, come on back. So you always leave the door open. And most people are responsive to that eventually. But,
yeah, just that kind of human touch like that, like I'm here for you.
Right. Or what can I find out for you? I like to go in and give people medical papers. They don't always understand them, but sometimes I find them like, wow, you guys really have thought of this.
That's impressive. Yeah. Oh my goodness. Wow. I'm wondering if there's such a disconnect often between just lay people and understanding even the process. And in this instance, like with Tuskegee, the process was deeply and culturally flawed.
Right.
But I'm thinking now you're talking about all of this, and I'm wondering, if in the future, if we look back and say, this what is the name of what they were doing or supposedly doing with the COVID virus before the pandemic, the proof of efficacy or whatever. I forget what
exactly.
Let's just try to ramp something up and make it hard to deal with, and that is that
biologic warfare. Yeah.
Well, I mean. Biologic warfare, but also just, in the interest of epidemiology, trying to take a coronavirus and make it more virulent so that we have to practice against it. It seemed like that's what they were talking about doing. Will there become a point where maybe the ethical line will move in such a way that sort of work will be out of bounds?
I hope so. I hope really what needs to happen is that the interest in finding out the answer from a purely scientific viewpoint actually merges with ethical consideration. So this would be really interesting to know, but do we really need to know it?
Right.
And why do we really need to know it? And what are we going to do with that information? And what if that information causes problems? Can we put the brakes on that? So, what's the value and what's the pros and cons? It's pretty straightforward, but I think people get wrapped up in the scientific,
oh, sure.
pursuit. Yeah.
So
And then,
when you were in school, how much of the ethics of things like this were addressed?
zero.
Yeah. Okay.
And it was not even, I went to school in Durham, North Carolina, in a big tertiary, at Duke, which is a big tertiary care medical center. And all the students and physicians and investigators at that time, was in 1985, were white. In fact, our class, out of 40 people, had one a person of Caribbean African descent, and one of, she'd probably call herself a Chicana. She was, at the time, that was how she described herself. So Hispanic descent from LA. And then one woman was, I think, from New York, of African American descent. And so 3 out of 40, and they thought that was diversity.
Wow.
I imagine that has really changed.
I would hope. I hope so.
Yeah, I would really hope. So people had the best of intentions, and almost all of their patients were color, but they didn't really look at kind of the deeper understanding of their experience. Color was, at that time, just looked at as a risk factor or not a risk factor. It's weird, because certainly was a poverty issue there too that was completely glossed over. So
right. And just as an aside, I think just our the racism in America, unfortunately, does gloss over the what I think are the real divides of poverty. But yeah, that's true.
Oh, completely. But if you're taking care of a kid with cancer and you're sending them back to substandard living conditions with an expectation they're going to do this and this and this because you've handed them written instructions that maybe nobody can really read or have the resources to carry out. I mean, completely glossed over. People had no idea that was a thing.
Wow. And
so it was kind of amazing. I did work in a family practice of a man of color, a physician of color, who had ties to the Gullah people. So I went over and took care of some Gullah people, and it was the difference in how he responded to them, as opposed to the white attendings, was day and night. It was amazing.
Yeah. So the Gullah people, are those the people on the islands off of
right?
Yeah, the Carolinas, the barrier area.
Mostly Southern Carolina, but he came from a community off the coast of Northern Carolina.
And what did you see? Just a more openness toward him as being a person of color too?
Oh, completely. And I actually benefited from that, because I did a lot of the gynecology, because they didn't want him, to do that.
Yeah, sure.
And so since I was with him, I seemed okay, even though I was a complete outsider and only there for a month or two.
But a woman too. You'd mentioned this in regards to the homeless clinic that happens every week up the street here, and how homeless women with gynecological concerns were really grateful to see you instead of the male doctor. And of course, I mean, just across the board, especially when dealing with things that are health related or confidentiality related, any of that, it's gonna feel better to see somebody who looks like you.
Probably, but the flip side is he's probably related to most of them too.
Oh, okay.
We have to remember this is a small community.
That's a whole different thing. Yeah, sure.
Yeah, it was an incredible medical experience. I'm really lucky to have had it, and it was a beautiful community. I don't know if anybody knows anything about the Gullah. They're pretty. I don't know how to explain it. They're very lighthearted people. They're very open and accepting, and they're definitely living in their element, unaffected by pressures from the outside.
Wow.
At least when I was there. So there is syphilis in Del Norte County. There's an increase in syphilis since COVID came out, mostly because people didn't access the medical care that they have to, but also because people think a full STD panel is a urine sample to test for gonorrhea and chlamydia, and syphilis is actually test for, at least initially, with a blood test. Now it's a finger stick. It's not even a, like a blood from your arm.
Right. It's just like an old-fashioned blood count, right?
Blood count comes from your arm. Finger stick is like the screening test for HIV.
Blood count comes from your. Okay, hold on. So when I was a kid and I get my finger pricked, when I always thought that was a blood count.
Oh, that was your hemoglobin. That was your hemoglobin or hematocrit. Yeah,
nobody
that
ever
was
said
only
that.
part of it. Yeah. What you were implying was a more sophisticated test, So finger stick, and at teen clinic, you can come and get it done if you want. But most people think if they peed in the cup that's the end of their responsibility, and it is. And especially if you have a new partner and you're like doing the right thing and you want to say, hey, I've been tested for quote unquote everything, ask if that includes a blood test. Because if it doesn't, it's not even close to everything.
Right. So, and this is something, so as far as, just as an aside, if we're talking about this, and you mentioned the teen clinic, what sorts of testing is available for teens at the teen clinic, and how quick does it take, and what's there?
So everybody's favorite, gonorrhea and chlamydia, that's a urine test. They've also added on trichomonas to that, and trichomonas is a pretty common infection that most men don't have symptoms of, but women have vaginal symptoms. So you can find that out by peeing in a cup. The blood tests that they routinely cover with, they're covered by insurance, but also recommended to get are, of course, HIV, syphilis, which we just said is now a finger stick, hepatitis C, which is a blood draw from the arm. Okay. And then hepatitis B and hepatitis A are technically sexually transmissible diseases in some part, but they're not really covered in this setting.
Okay.
So insurance doesn't really pay for them, but Medi-Cal would if somebody had Medi-Cal. And I'd be glad to test anybody who comes in, although it's specifically a teen clinic and our numbers are up and we're super excited to serve the teen community at Del Norte. We also, the occasional worried individual comes in who might be outside that age group, and we're happy to help.
That's wonderful. And the hours again for the teen clinic?
Teen clinic is Tuesday afternoon from 1 to 5.
That's it?
Yeah.
Okay.
That's it. It could be Wednesday too if there was a community interest in it. So just plant that seed. Yeah.
And then, of course, that's here in Del Norte. That's across the parking lot from the high school, right there on the CR campus, the Del Norte CR campus.
Right.
All right. So in the couple of minutes we have left here, Lynn, how in the world do we wrap this up? How do you restore trust in in medicine in America among people of color?
I don't know that any individual can do that. I think we're off to a good start by not experimenting on people and having like review boards, the ethical review boards that are quite strenuous to get a study through. But I personally think every day somebody should wake up, especially a white person, and think about how they might go through their day and how they might encounter insidious racism. Mm-hmm. That's super subtle and more of a result of their lifelong indoctrination as a white person, and look for it and be aware of it and resolve to change.
Right. And I think
that's what I think. Every day you have to look in your soul. I
think specifically with with what you do, with being a physician assistant. Yeah. I was just looking up numbers while we were talking about all of this, and I don't know if these will be helpful, hopeful, or whatever, but the most common ethnicity of certified physician assistants is white at 70%, followed by Asian at just over 10%, Hispanic at 10%, and Black or African American at still only 5.6%, which is way under that's about half of what the larger percentage for the larger population would be. So still, as far as it's still underrepresented in that profession, and it seems like that's kind of the place to start. As we were talking about, seeing somebody who looks like you, who has the same sorts of cultural references and maybe the same experiences that you have when you're in the exam room, that would be the quickest way to undermine that lack of trust.
Yeah, I think so. So I think white PAs ought to be open to mentoring, but they have to be very careful that they're not going in there to save people of color.
Right.
They have to be the door that the mentee goes through onto, because I've mentored, I don't know, 15 people and gotten a lot of people. I mean, these people have gotten into school on their own power, but I was able to assist. So, maybe if I can, and they're all white. So if I can start assisting a variety of people and just be the door that opens, and they themselves can go through it through their own skills and abilities, then maybe that's the way I personally can do it. And that could also be extrapolated to other professions quite easily.
Right. Well, Lynn, thank you very much. This was, I don't know, this was kind of a breath of fresh air diving into these larger social issues and talking about a historical thing like this and sort of dispelling some of the misinformation, things that I thought they were giving these airmen syphilis. I even had that.
They're not airmen. They were random members of the community. Wow. They were confusing it with Tuskegee Airmen, although one went on to help found that program.
Oh, okay. I see. That's good. That's good to dispel all of that. Cool. Well, thank you very much, Lynn, and safe travels, and have a wonderful visit with your folks, and we'll talk again this next week on the next Health Matters.
We will. Thanks.